Okay, good morning. This video is going to be for the whole 2 weeks of the respiratory system. As usual, I advise you to read the book and the presentations and see the videos. You can choose whatever you want to study the best that you can. And as usual, I want to ensure you that you actually know most of the materials. You've taken advanced exercise phys. You know anatomy, you know physiology, you know exercise physiology, and all we're doing, if you notice, is combining them together. So we're actually using very small blocks of information that you know, and we're just connecting them. My advice when you're learning is going to say the same. Understand the anatomy. Anatomy is crucial to understand physiology. 2, identify the mechanisms and principles. They usually reoccur, and you can identify them happening again and again and again in every condition. And I'll identify them for you and explain them once more, but you'll notice that it's reoccurring. It's the same principles that we're playing with again and again, and all you need to know is to understand how to apply them in the right disease and condition, obviously. And it's not too much, by the way. Identify the unique symptoms. Unique means that that you don't see them in other cases. I have indicated them either in bold or in blue in the presentations. But at the same time, notice that there's a lot of symptoms and causes and treatments that just are given or are seen in more than one condition because it's the same system. So identify the unique causes, identify the unique symptoms, identify unique treatments, try and remember them, try and connect them to the reasons of that disease, and you'll find out that most of the diseases have minor changes between them. Okay, let's go over the principles and let's understand the principles. And I expect you to be able to go over the presentation and go over the conditions and diseases and say, oh, here's this principle. This principle applies, this one doesn't. What are the outcomes? So let's go over it. First of all, as indicated in the presentation and in the book, and it's impossible to escape it, when you're talking about the respiratory system, you are dealing with the environment. It is a system that has a direct connection to the environment. So any changes in the environment, for instance, in oxygen content, in CO2 content, in toxins, especially toxins that are very potent, any small changes there may lead to very big changes in the body. It doesn't have to be only toxins. It can be dust. It can be any kind of particle that is in the air. It can be viruses. So when you're connected to the environment, it has a cost. And you're going to see that cost first through the respiratory system. And that is a major way of getting into the body. So you must understand that infections and inflammations are day-to-day standard processes of this system. And notice that the majority, if not all, actually, of the conditions that are abnormal at some point include, for sure, inflammation. And a vast majority also include infection. So those two are always there. And you know about infections and you know about inflammations because you had already a chapter on the immune system. So you know about that. That's not new to you. So those are two major principles already that you know about. They are simple. Don't lose proportion. So one, we are connected to the environment. Two, changes in the environment lead to changes in the respiratory system, either by infections, toxins, or mechanical changes due to the concentration of the content of the air regarding O2 and CO2. When we're talking about the respiratory system, we're thinking about three major processes. Ventilation, which is in this case mechanical, that's why it's called gross respiratory, as opposed to cellular respiration. We have diffusion, and we have perfusion. All three are part of the system. Okay? So when you decrease or increase ventilation, you are immediately affecting all the tissues of the body. Alright? Obviously, decreased ventilation, especially at rest, is worse than increased. Increased ventilation is normal if it's not due to a disease. So for instance, our field of exercise is exactly that. We increase people's ventilations for a certain period of time, and we do it on purpose. The problem is it increased because of a problem. So for instance, if the delivery of oxygen is not high enough or is not normal, you will have to increase ventilation to deliver the right amount per time. So that would be a problem in oxygen delivery or perfusion of the cells. And now you have to work mechanically harder, meaning respiratory work or breathing work or energetic cost of breathing, all the same things, in order to achieve the same outcome. So ventilation, diffusion, meaning the ability of oxygen to enter the bloodstream, and we also want to remove CO2, so that would be diffusion of the CO2 from the bloodstream to the lungs, to the alveoli, and they're always in counter directions, right? We talked about that. And when one of two or both of them are not adequate, we start seeing problems. If we're talking about efficiency examines the cost of the energetic cost per outcome. So if you are not efficient, you are going to pay or invest more energy to receive the same outcome. Now, if you look at the anatomy of the respiratory system, we are talking about the cartilages that we have down the larynx that on the one hand stabilize the system, so you don't have your airways playing all over the place when you move, which is very inefficient. But the downside of the respiratory system is the fact that cartilage has pores in it. It has cavities in it, and those cavities tend to trap air. So when air goes down, it also goes sideways into those cavities, and we're actually starting with a loss of 30%. 30%, not 3%, not 13, not 23. 30% loss of the volume that you brought in. That is even before it has diffused, and even before it's perfused, and even before you're able to carry it in the blood and utilize it in the muscles. So the efficiency is going to be less than 70% in average. So that volume of air that is lost due to anatomical reasons is called the dead anatomical space or volume. Okay. and that's normal. So out of a tidal volume of about 500 mils, you're going to lose about 150, give or take a bit. So the respiratory system starts at 70% and it goes down from there. Any physiological reason, a disease, a physiological condition, mechanical problems, will create what we call the dead physiological space, which is always added to the anatomical dead space, meaning lowering the efficiency of the system. The respiratory system in the airways is built in such a way and functions in such a way that it's supposed to improve the movement or airflow through it. So we want the air to be clean. It allows the air to move faster and quicker. And of course, we have the immune aspects that we do not want foreign bodies going into our body. We want to heat the air. The heat makes the air move faster and is a source of energy that can be used. And we want to humidify the air because we don't want it to extract fluids from the cells, because you'll have a gradient, and that will cause water to leave the cells, and we don't want that, right? And in addition, when you humidify the air, it just slips down the airways and goes faster. So we definitely don't want the air to be dry. So in normal conditions, our respiratory system cleans, heats, and humidifies air, and any changes in that will change the function of the system. Let's differentiate between the upper part of the respiratory system and the lower part. First of all, besides the fact that the upper you go, the bigger the vessels and the airways and the construction of the components of the system are. The lower you go, the smaller they get, all the way down to the alveoli. So that's one distinction. The second distinction between upper and lower is the immunal aspect. You want, as much as possible, to prevent anything that should not enter from reaching the lower respiratory system. So the innate immune system has a lot of physical barriers, which you have heard and learned before about, in the upper tract of the respiratory system. It also has a few limited possibilities in the lower respiratory system, but once you hit the lower respiratory system, it's basically going to be dependent on the adaptive immune system. We do not want that. But you'll see in the majority of lower respiratory diseases and conditions that we have an immune response. I hope you said it in your mind. You're correct. Infections that lead to inflammations, and we know that when an inflammation starts, hopefully it's either self-contained or contained fast treated. If not, it can spread throughout the body and cause multiple organ damage, and that would be a severe outcome, of course. And the way to spread through the body, and you do know this, is by the bloodstream, by the circulation. And once it hits the systemic circulation, everything is open. Every organ, every possibility. So that's very severe, and we want to catch things before that happens. So we have those physical barriers, as we said. Specifically, we have mainly the mucus, and we have the sialylated cells, and we see in the more advanced slides of the presentations, and of course as the book advances, that those two barriers can be affected during disease and respiratory conditions. Let's talk about the alveoli. The alveoli, of course, are the lowest part of the system. A very important part. Actually, everything above the alveoli is meant in a way to serve the alveoli. And the surroundings of the alveoli are built in such a way and function in such a way that they serve the alveoli. Why? Because the alveoli is the site of function, whereas we have the gas exchange. Without that gas exchange, the whole point is lost. There's no point in delivery if you're not having that gas, mainly oxygen, diffuse into the blood and CO2 removed from the blood. So that is a very important structure, and the alveoli are perfectly built in order to allow good, great, almost perfect gas exchange. Part of the ability to prevent the alveoli from becoming wet, because moisture does not work well with the idea that we want gases to move, that those fluids will capture the gases. If they're captured in the alveoli, they do not move into the blood. We do not want that. All right. So we need to prevent the alveoli from becoming wet. One of the solutions is a substance called surfactant, and it generally coats the alveoli. When the production of surfactant or the coating itself is damaged or decreased, fluids can come into the alveoli, and now we have two problems. A, they're going to absorb gases. We don't want that. That will decrease the gas exchange between the lungs and the bloodstream. Second of all, do you remember that fluids cannot be compressed? So now you have a mechanical problem, because the mechanical pressure within the alveoli is elevated, and the ability to expand the alveoli and the ability to contain more volume is decreased. So that will make the alveoli a lot more stiffer, and by that it will also influence the general mechanical work of the lungs. And if the mechanical work is increased, so is the energetic cost. Mainly, surfactant prevents collapse of the alveoli during the expiratory process or phase of breathing, because it keeps the tension of the alveoli exactly what it needs to be. We have the alveolo-capillary membrane, which is that thick membrane that separates between the alveoli and the capillaries. We want that membrane to be thin, so any thickening of that membrane is going to cause a gas exchange to be lesser or slower, or both. So we don't want that, and you'll see that a few conditions affect the alveolo membrane thickness. In addition, it might affect its permeability, allowing fluids to enter, and we already discussed that. Obviously, fluids that enter are going to end up with edema. It might end up with an inflammation and mechanical resistance. We have the pleurals, which slide over each other during different phases of respiration. We want them to be able to slide over each other, and we need to have a negative pressure between the two of them. Anything that will change those two things that I just said, A, the ability to slide, and B, the negative pressure between the two pleurals is going to damage or decrease the respiratory mechanical work, meaning that we will have a problem. The lungs won't function mechanically, the costs will go up, we'll have problems with ventilation. When you have problems with ventilation, it's going to affect diffusion, it's going to affect perfusion at the end. So they produce a mechanical force that helps us vent the alveoli, right? What can interfere? So we see that we can have particles in between those two pleurals. Not a good idea. We can have organisms, and then inflammation. Inflammation always comes with volumes, with fluids. Not a good idea. We can simply have fluids enter that space between the two. Not a good idea. We can have air caught and trapped in between those two tissues in that space. Once again, not a good idea. So anything that comes in between those two pleurals and affects the pressure is not a good idea, right? Now we see one condition in which air is trapped but is also released during one cycle of ventilation. And then we see a unique condition where air is constantly added, changing the pressure, and when the pressure changes, then all of the problems occur. Right, excuse me for a second. We have the analysis of regular ventilation or respiration versus increase. During regular respiration, we have the DRG bundles that take control, meaning neurological control of the nervous system. And during increased effort due to disease or exercise, we have the VRGs. At the end of the day, or during the day, at any given point, the brain wants more than one source of information. So the brain utilizes different kinds of receptors to receive that information. The overall picture that is received by all of the receptors cause regulation of ventilation, of respiration. So those would be receptors that are able to indicate changes in tension, changes in gases or dust, and changes in pressure. The nervous system has these receptors spread out through the body in strategic places, and information is gathered, and according to the information, minute ventilation is regulated on a second-to-second basis. And just so you know, I haven't wrote that in the presentation or in the book, and you don't have to remember this. This will not be in any exam or quiz, but just for the general information, you have about 40,000 cycles of regulation per second. It's that accurate. If we want to control ventilation, we have to control the diameter of the airway, which is usually controlled by the parasympathetic system when everything is okay, at rest when everything is normal, and by the sympathetic system when things are not normal or increased, like in exercise. Another very potent influencer of ventilation is pH. So we use chemoreceptors to sample the pH of our arterial blood and through the CSF. When you do that, you get a very accurate indication of the pressure of O2 and CO2 that you have, CO2 being a result of hydrogen ions, and that equilibrium that is generated that we talked about, the wish to find that equilibrium between gases, between particles, between pressure, and so on and so forth, is the one that allows us to understand the changes between 2 points in the body, and the brain definitely uses that to understand and regulate ventilation. So remember, arterial pH is the one that a major component, a major component that is regulating ventilation. When are we going to use the accessory respiratory muscles, either inspiratory or expiratory? When we need to produce increased pressure in the case of expiration, and very low pressure, negative pressure, in the case of inspiration. So that's either increasing the volume of the cavities of the body, that would be the thorax and the abdomen, in inspiration, and decreasing them during expiration. Other than that, it is built to be and planned to be very efficient and actually mostly passive. All right. Let's talk about compliance. The compliance of the pleural tissue is very important for function, for mechanical function. Basically, compliance is the amount of resistance that the system is presenting to airflow. So the higher the compliance, the more resistance you have, and the harder it is to vent, and the breathing, mechanical work, and cost of the system goes up. Compliance is the ratio or relationship between the elastic recoil, the ability of the lungs to expand and immediately tend to go back to their original situation, versus the ability to inflate the alveoli. The ability to inflate the alveoli depends on the tension of the alveoli and depends on the diameter or the radius of the alveoli. So the higher, the better the elastic recoil, the lower the compliance, and the lower the resistance, and the better the airflow, and vice versa. Partial pressure is also a force. So when we take 1 liter of air, it consists of different gases and vapors, and under normal conditions, 1 liter of air will generate 1 barometric pressure, which is 760 millimeters of mercury, Hg. But it's the whole liter of air that is producing that. But when we look at a normal liter of air, under standard pressure and conditions, the oxygen itself as a gas is only 20.93%. So from the total pressure that 1 liter produces on the environment, 20.93% of that is from the gas oxygen. If you look in a biological system, such as the respiratory system is humidifying, adding water to that air, so you have to, and that decreases the pressure, so you have to take that in consideration. Gravity works and influences everything. So according to the posture of the person, gravity is going to affect the respiratory system in a different way. So there are postures where certain areas of the lungs can vent more because the resistance and the influence of gravity is lower, And in the same position, there are areas in the lungs that are affected in such a way that it decreases the ability to vent. And then suddenly you change position from let's say lying down to standing or sitting, and the influence of gravity changing what areas of the lungs can be vented more or less. So it's not evenly distributed in every position of the body. We have a ratio. Which we call the V to Q ratio, and it's the ratio between ventilation and perfusion. Under normal conditions, in general, we want perfusion to be greater than ventilation, and we want that ratio to be about 0.8. Right? That means that ventilation is lower than perfusion. When that ratio is changed, it can be due to two reasons actually, not conditions. Two reasons. A, different areas of the lungs have a different ratio normally, because of the size of the alveoli, because of gravity, because of the ability to vent them, and so on and so forth. The other reason, which is greatly respected and addressed by us through the course in this chapter, is obviously some kind of pathology, disease, condition, and that's one indication to what happens. When that ratio decreases, usually you understand that you have a problem with ventilation. When that ratio increases, you understand that you have a problem with perfusion. So it's actually a very simple ratio, but allows you to understand what part of the system, what process here is problematic. And then we have the ability to perfuse the cells and the tissues. Obviously, you have a carrier called hemoglobin, and if it doesn't release oxygen, you're not going to get it. It's that simple. So those are the few humorous. I hope you understood the jokes there with taking candy from a child. There are certain conditions whereas hemoglobin will release its oxygen to the cell. So and you have the curves. You have a left shift and a right shift according to the reasons. At the end of the day, under normal conditions, we want the conditions to be such that promote the release of oxygen when hemoglobin reaches the cell and the arterial circulation, and accepts CO2 in the venous circulation, and not vice versa, obviously. Smoking. Sometimes I wonder if I really have to talk about it, but yes, we do, just to make sure. Smoking damages the body by affecting the alveoli, by creating hemodynamic responses and damage, by damaging the innate immune system in the airways, which we already explained the outcomes of that, and it has psycho-emotional influences and damages. Let's start with the alveoli. I think you saw the pictures. A cigarette has tar in it. Tar coats the alveoli, preventing diffusion. If diffusion is prevented or decreased, you have a problem with perfusion, and when you have a problem with perfusion, you're asking for it. We, I think, established that point in different words and ways, during the circulatory and the cardiovascular system. So hypoxia is not a good idea. Severe hypoxia even less. The more alveoli that are coated with tar, the worse you are off. If we're talking about hemodynamic responses, we're talking about the nicotine, which elevates blood pressure, causes damage to blood vessels, and that can lead to inflammation. It can lead to boluses. That can lead to stroke, to a heart attack, you name it. We already know all the influences of smoking on the vascular system. When we're talking about the innate immune system, we're talking about affecting the mucus that is supposed to capture allergens, dust, foreign bodies, infections, bacteria, and it also affects the ciliated cells that also are supposed to grab particles and foreign bodies. So that would allow all those threats to go down to the lower respiratory system, and as we said, we are a bit more defenseless down there. We do have defenses, but it's going to cause inflammation, and inflammation in the respiratory system is going to have its costs. When we're talking about psycho-emotional responses, one of the problems with smoking is that you get hooked. You get hooked emotionally, even before anything else, by the way. It changes the physiology of the brain, and it produces either depression or elevation of spirit, and it can change your psyche. So those are very serious forces to deal with, and that's why it's so hard to stop smoking. By far, the outcome that is impossible to reverse is the tar in the alveoli. Alright, let's talk about the second presentation. I'm not going to go over every condition, and I do that on purpose because I want you to be able to adjust and establish that mechanism where you apply the principles to a condition. Physiology is about the principles and the ability to apply them at the right time, at the right moment. So let's talk about the principles. We just talked about upper and lower respiratory systems. Sorry. When we're talking about the alveoli, we're talking about the ability to inflate them. Inflation will depend, obviously, on the amount of ventilation, the amount of air that you're trying to get into the alveoli, the surface tension of the alveoli, and the size of the alveoli, the diameter of the alveoli. So you have that interaction. We can talk about perfusion from the bloodstream to the tissue. Obviously, this tissue is alive and has to be perfused in order to function, otherwise it will die. We have diffusion through the alveolo-capillary membrane that we talked about. We want its permeability to be a certain value. When this membrane is thinned, it improves function. When it is thickened, it decreases function. And when we're talking about the system in general, we have the formula that ventilation equals tidal volume times respiratory rate or frequency. The hallmark symptom of a problem in ventilation is the decrease in VT. When VT decreases, mathematically, respiratory rate has to increase unless there's a reason to decrease respiratory rate. If you're breathing, for instance, very shallow and slow, meaning that you have some kind of interference with your nervous system that is causing everything to calm down. For instance, a good reason for that happening would be if you are hypocapnia right now, you want to lower your ventilation in order to preserve CO2 until the situation is resolved. Hypocapnia obviously corresponds with alkalosis. We have infection, very simple. I don't think there's much to say here. Any foreign body, any bacteria, virus, fungi that we've learned about that will enter the system will cause an infection. An infection leads to inflammation and a whole immune response. Inflammation can be caused, in addition to immune reasons, by mechanical reasons. So that would be basically friction and mechanical injury or physical injury of a cell and tissue. Let's talk about the major responses that we see in the system. There's all kinds of responses, but if you go condition by condition and analyze them and write them down, you're going to find that most likely a person is going to display with dyspnea. Very, very common. So there's nothing new there, right? Hypoxemia, which is the equivalent of hypoxia only in the respiratory system. So it's easy to get confused. So that would be a decrease in the perfusion of the lung tissue. Very common. You're going to see it every time, again and again. So those two are very very usual. You have a cough, which is an exploding respiratory response to something that is caught physically in the airways. Very usual. You can have pH changes, so that's due to changes most likely in CO2. So that would be if you have hyperventilation, you are going to lose CO2 and you're going to cause alkalosis. And when you have hypoventilation, you are not losing CO2 enough and you're going to have acidosis. We have pain. Pain is any pressure, mechanical pressure over a nerve. So if you have compression due to fluids, due to a tumor, due to inflammation, anything that is uploading the mechanical pressure on a certain area which is innervated, you're going to feel pain. So that's pleural pain, and that is an indication of a mechanical obstruction. We have changes in the mucosa that we talked about, so anything that would affect the mucosa and ciliated cells, affecting the innate immunity aspect, which will lead to infections, that will lead to inflammation, that will cause pleural pain, decrease the mechanical ability to work, elevate energetic costs. It all recycles all the time at some point. We have changes in the patterns of breathing, so that would be changes in the time or the ratios between inspiration and expiration. You might have a pause between the two that is too long. And of course, when you have mechanical influences, when you have fluids or solids in the system and you want to deliver or circulate air through it, it's going to cause sound. So we have all kinds of sounds that we can listen to, and according to the position, we know what's going on. So you'll see that in the symptoms and also in the diagnosis. Always, no matter what you're doing and what system we're talking about, if a person is aware of a difficulty and is in stress, he or she might react with anxiety. Anxiety obviously is a matter of the brain. So you're going into psychological aspects, and that of course will alter the function of the person. So obviously such a person has to calm down or be calmed down in order to not worsen the situation. We spoke about elastic recoil, we spoke about hypercapnia. Okay, let's talk about the connection of the respiratory system to the systemic circulation and the pulmonary circulation. Obviously they are connected. We spoke before that is our anatomy, and when things leave the system and enter enter the circulation, the systemic circulation, then all of those causes are now traveling in your body and reaching other tissues, and those are severe cases. And then you see that the respiratory system is influencing the cardiovascular system. But it also works the other way around. When you have a problem in the cardiovascular system that impairs perfusion, you're also impairing the perfusion of the respiratory system, and then you're going to have problems in the respiratory system. So when such conditions are not treated, they tend to expand and cause what we have already called multiple organ failure or injury or damage. The nervous system. The nervous system has very tight control and regulation of the respiratory system, and that means that any problem in the nervous system will affect the respiratory system as well, and immediately. So any problems in conductance will influence the regulation, supervision, and activation of the respiratory muscles, the intercostals, the either external or internal, the diaphragm. So we'll see that. So any kind of psychological disorder may cause a respiratory system, and you'll see a few conditions. As we said, stress, psychology, anxiety will take its toll. So these are the major principles. I'll just say one last thing. When you look at the diagnostic tools and the treatments, they are very specific according to the causes of the condition. Of course, when I write or when we say antibiotics, it really depends antibiotics to what. So there's no point in starting to write every antibiotic possible, because that would be completely crazy. But I'm sure that you get the drift. I hope you learn well, and enjoy the rest of your day. Bye.